delegate the following. The registered nurse cannot delegate the following: assessments that identify needs and problems and diagnose human responses. The RN is required to know the level of care required. But again, if a patient, so we already know that RNs have to take the patient that's being admitted because they have to do the total assessment, identify the plan of care, and those things. But also, if a assessment, a focused assessment is identified by the LPN that there's a problem, it's the RN's responsibility to go and to follow up on it, or any patient for that matter, or any situation. No one can initiate a plan of care. Only the registered nurse. The LPN can update the plan of care. Say, for instance, there was a wound, and the wound, maybe it was a skin tear, and now it's healed. The LPN may be able to do specifics, but they cannot initiate a plan of care. They can follow the plan of care, but they cannot initiate the plan of care. Or the total plan of care. So the LPN cannot teach, they cannot refer, so that's why they cannot discharge patients, because discharged patients require a lot of teaching on their discharge. I know when that's doing that, I still have my email. So we know that the LPN cannot assess unless it's focused, plan, teach, do the evaluation of, say, the nurse had to go in to give some kind of treatment, medication, or whatever. Say for that patient that has developed an allergic reaction to a medication, and they gave them Benadryl. Then, in the perfect world, the RN would come back to evaluate: is it better, or is it digressing into anaphylaxis? The American Nurses Association has delineated activities that the RN cannot delegate. So again, it's that initial nursing assessment that would be on a newly admitted patient. They cannot determine, they can only determine the nursing diagnosis, establishing nursing care goals, the nursing plan, the evaluation of the client's progress, help counseling or teaching, and then activities that require specialized nursing knowledge, skill, and judgment. One of my friends who works at the hospital, she did have a prisoner that was incarcerated with a new onset of heart failure. And she went in and started teaching him, because she knew he was going to be discharged that day, about his medications and his care. And he said, "Thank you, no one's coming here to tell me anything." Maybe just because they were busy. So as far as the UAP activities that can be delegated by the RN to the UAP, they pretty much have to be routine and basic to assist the client in meeting basic human needs, such as feeding. But now, could you delegate the feeding of a client that was dysphagic
No.
to a UAP? No, they're unstable. The LPN could do that, and the RN, but the UAP could not. Again, drinking, positioning, ambulating, grooming. Could you assign the ambulation of a patient who is getting out of bed for the first time? Or maybe a patient that's getting out of bed and they're requiring crutch walking, walker assistance. Could you delegate that to the LPN? Any kind of special requirements that would cause them to be unstable, and again, that would be the patient for the first time in bed, anybody, amputee, they could do the cane, the amputee, the walker, if they have been trained to do so. And then they have been documented as competent. Then you could do that. As far as still, the first time out of bed, the RN should always do that, or the LPN. The LPN could do that too. But it would take a nurse collecting of specimens, but they cannot collect sterile specimens. And then collecting, reporting, and documenting data related to the above activities, such as they could, document that the patient did get their bath, and they did eat 50% of their food, and their eyes and nose. I feel like sometimes with this, I'm preaching to the choir already, but maybe not. So, RNs can delegate the following activities to LPNs. So, administering medications. But again, we have to think what those medications are, because TPN is not one of them. Any kind of cardiac medication, IV, any kind of IV therapy, medication, the follow-up to those medications. So the RN can delegate dressing changes, even sterile dressing changes, irrigating wounds, suctioning, urinary catheterizations. And the LPN can use the nursing process, but they cannot initiate it or analyze the data. So, other policies related to delegation of the RN, they may delegate only what is within the scope of nursing practice. LPN works under the direct supervision of the RN, know the legal scope of practice for the LPN. And also, I've already said, if you work somewhere that they have the medication assistance, I would know the legal practice for them also. RN determines, you've got to determine the competency of the delegatee. And so if you had a situation where a UAP had never performed a transfer before, patient was stable, then you could teach them and let them demonstrate safely. Because that's another way they learn and they become competent, is that it's through us as the registered nurse that we also teach them, and then they demonstrate back to us the competency. The RN is, of course, accountable for the delegated task, and delegation requires critical thinking, again, knowing that the UAP, particularly the LPN is the stable patients, and the UAP's tasks are simple and routine. Competencies. So staff members must have the skills and knowledge necessary to perform a task before it is delegated. So again, that goes back to, and you may get questions asked about OB or psych that is pulled, because even though they are a registered nurse, that is not their familiar area, so you would be responsible for the patients that you delegated. That was my issue in the intensive care unit when they pulled someone there. I couldn't give them a ventilator patient. I couldn't give them, I could give them, well, it was difficult with the medications that were infusing. They may as well, it was very difficult in the ICU when they pulled an OB nurse and a psych nurse in the ICU. But that's been years ago. I hope they wouldn't do that again. Other than that nurse could do, pretty much they would work as a tech. I would have to work as tech in the ICU. Competencies confirm the individual has demonstrated specific knowledge and skills. And if you have to with UAP, you could do that, as long as it was not a skill that was a sterile procedure, because regardless, you cannot assign a UAP to obtain a sterile specimen. Regulatory and accrediting agencies such as the Joint Commission require written documentation of competencies. So, you know, every year, skills fairs, they do those where even the RN and the LPNs, they have to come down, they have to be, they have to demonstrate that they're still competent to run the glucometer. Again, blood is one that's very important. Any kind of new equipment that they have, that the hospital has obtained over the last year, even though you may have been using it already, they have to do a skills fair, and that is part of the Joint Commission accreditation, and I think I already mentioned that. But that has to be done yearly. I know Ms. Samet, she fed my 113 students because they've got a lot of stuff going on at Gadsden Original to recruit nurses, but she was saying she was having to work on the skills fair coming up, so that every nurse goes through to familiarize themselves with procedures of high importance, and blood is always going to be one of those. Blood administration. The glucometer also. And also, the competency should be part of it as knowing the competencies of the staff that he or she supervises. So again, going back to, if your hospital starts hiring the medical assistants, giving medications, you better know what their legal practice is, or what their practice is, especially if they're giving medications. So, organizations, policies, and procedures. The specific skill and supervision requirements for various tasks are designated and written in policies and procedures. But we know the Nurse Practice Act trumps policies and procedures, although they should align with those. Ensure that the delegate is trained and understands the organization's general statements of care as well as standard procedures. If they do not, then you should not assign them unless you can take the time to teach them and to demonstrate, and it would still be a simple task. So the follow-up, the delegation process is not complete until the RN reassesses the client and adjusts the plan of care, provides honest feedback to the delegatee about his or her performance, praise good performance and address poor performance, stop inappropriate, unsafe, or incompetent performance immediately, document and report to the nurse manager or supervisor. So again, that's part of the nurse's code of ethics also, to report unsafe nursing care. But as the registered nurse, especially if you're the delegator, the charge nurse, then it's your duty additional training or appropriate action to ensure the client safety is protected. So, if there's staff that are new, that you're just constantly feel like you're having to teach them something that they were not trained effectively in wherever they got their CNA certificate or. So, the RNs, they teach, assess, plan, evaluate. That cannot be delegated. Teach, assess, plan, evaluate. I mean, evaluate so much as, recently there was a patient that was being discharged and they had had an IV and there was a pretty bit of redness around the insertion site. So, I called the nurse that was caring for the patient, and the main thing that bothered me was that that patient was also a diabetic. So, we put Neosporin on there, and I don't know if he documented it on the notes. LPNs can reinforce teaching that the RN has already performed. They can do focused assessments, stable client care, and I've already spoke about reassigned staff should care for similar patients, and you must know their competency level. And even you, when you are being, and I've already spoke on that, sent to another floor, you want to first find out what your responsibilities are going to be as far as caring for patients and what type patients they would be. Again, especially like my situation when I went to the OB floor, I was lost as goose. UAP, again, simple, repetitive task that does not require nursing judgment. Collect specimens, but not sterile, and you can collect a sterile specimen and the UAP can transfer it to the lab for you. Non-invasive procedures, they can ambulate stable patients, but again, not for the first time, that's always a catch. In a question, or it used to be. And then sometimes they may need demonstration first, and that is our responsibility to, if there's a particular situation and you can teach them, and then evaluate their understanding. And this is another thing. Nursing staff should not perform the duties of the UAP. Why is that? Well, I'll put it on here. It is not cost effective. So if nursing staff are having to bathe patients, and that does happen sometimes, but if they're having to do the personal care for patients, then in this day and age, not only is it not cost effective, it's not safe for the patients that they are having to take care of. And the UAPs don't understand this. They get upset, and I understand, but maybe it's better because hopefully they're getting better pay now. But the UAPs, they always want to say that RN is just sitting there charting, or, although I don't even see many RNs at the desk documenting much these days. I don't know where they're documenting.